Axonal polyneuropathy. So, the vast majorities of polyneuropathy, the pathology what we see is axonal. So, the causes of axonal polyneuropathy or most common cause is diabetes. And there are also some genetic causes. Of these acquired causes, diabetes is the most common cause of axonal polyneuropathy. And the other causes include toxins, usage of drugs, and nutritional neuropathies, which is secondary to B12 deficiency, B6 deficiency, B1 deficiency. They are all axonal neuropathies. The pathology is axonal involvement. Metabolic causes like any hereditary diseases like adrenomyeloneuropathy and hereditary ataxias like Friedreich's ataxias, they have neuropathies and they also or the pathology is axonal degeneration. And endocrine causes include hypothyroidism. The neuropathy is axonal. And connective tissue disorders, which is rheumatic arthritis or other vasculitis, can cause neuropathies, which the pathology is axonal. Axonal is a nerve has a cell body and a axon. So this is a cell body and this is a axon. This is a neuron. So axon is covered by myelin sheaths. It's covered by Schwann cells, and Schwann cells produce myelin sheath. And when the pathology is here, then it is called axonal neuropathy. When the pathology is involved in the myelin sheath, then it is called demyelinating neuropathy. So here our discussion is about axonal neuropathy. So what are the clinical features of axonal neuropathy? So any neuropathy, any nerve has, this is a cross section of nerve, any nerve has sensory fibers, motor fibers and autonomic fibers. These motor fibers are the largest one and autonomic fibers are the smallest one, and the sensory fibers have both large fibers and small fibers. Of them, when the axon is involved, even if it's a large or small, axon is involved, first the symptoms start in the legs. So if we think this as a person, hands and legs, the first symptoms start at the feet and then they progress upwards. The symptoms could be sensory symptoms depending upon the sensory nerve involvement, motor symptoms depending upon the motor fibers involved. So the symptoms start from the feet. It could be weakness or numbness, tingling sensation, pins and needle sensation. They start in the feet and they progress upwards. And again, when the symptoms reach the upper calf, then the symptoms start in the hands. The symptoms start in the hands, fingertips, and then it progresses upwards. So, and next, when entire upper limb is involved and entire lower limb is involved, then the symptoms are seen in the anterior chest. So, then the symptoms start in the anterior part of the chest. So this anterior part of the chest, the symptoms are secondary to this intercostal radiculopathy. The intercostal nerves, they start from the posterior back, that is, it is the vertebral column, this is spinal cord. They start over the posterior part and they surround the thorax and they supply the anterior part of the chest. So this axonal neuropathy is a length dependent neuropathy. So the longest fibers are involved first. The longest fibers are the foot fibers, means which are supplying the legs and feet muscles. So when these are involved, the next longest fibers are the hand, means the fibers which supply the hands. So when these are involved, the next longest are the intercostal nerves. So involvement of the intercostal nerves causes decreased sensations over the anterior part of the chest, and next they present with involvement of this sensation, decreased sensation over the head, that is the scalp. This is secondary to the trigeminal nerve and cranial nerve involvement, cranial nerve, cervical cranial nerves involvement. So first it starts with stocking and glove pattern. This pattern of involvement is called stocking glove pattern. So first in the legs and then in the hands, and then it spreads to the anterior chest and abdomen, and then it is the sensory loss is seen over the head. And what are the nerve conduction findings? So when how do you diagnose it? So when we do nerve conduction studies, we see of three parameters. The first one is CMAP, that is compound muscle action potential. Second one is sensory nerve action potential, and velocities, conduction velocities and latencies. We see of amplitudes, velocities and latencies in the nerve conduction studies. If it is axonal neuropathy, in the sensory nerves and the motor nerves, the amplitudes will be decreased. And the distal latencies, conduction velocities will be very slow or normal. That slow is, it's a mild degree of slowing. It would be milder than that of a demyelinating variety, where we see the conduction velocities are less than 75% of lower limit of normal values. If it is an axonal neuropathy, it would not reach to this level, but the conduction velocities would be slower, but it is never less than 75% of lower limit of normal. And all these findings are seen more in the lower limbs than compared to that of upper limbs. And what are the EMG findings? In the EMG, we will see denervation picture more in the lower limbs, that is seen within weeks of presentation. So in EMG, we see denervation picture both in the lower limbs than that of upper limbs, but it happens within weeks of presentation. So less than 1 week, we can't find any denervation pattern in the EMG. Denervation pattern includes presence of fibrillations and positive sharp waves. And when this denervation happens, again the reinnervation happens in months. So the presence of denervation and reinnervation pattern is suggestive of axonal involvement, that is axonal neuropathies. But there are some special situations where there would be some confusion that if this axonal neuropathy is present or not. So in all the axonal neuropathies, distal extremities CMAP is decreased. So all axonal neuropathies, they first involve the distal extremities. The CMAPs are decreased in the distal stimulations, means over the feet. So mainly studied or sural snap study. It in all the axonal neuropathies, the sural snaps are decreased, means sensory nerve action potentials are decreased in the sural nerves when we examine. But there are some special situations. For example, in the younger individuals, they have very much higher basal sural amplitudes than that of older individuals. For example, the young individuals, they have a very high baseline amplitudes than that of older individuals. So if an young individual has an amplitude of 30 microvolts, if he has a axonal neuropathy, if it is decreased to 15 microvolts because of axonal neuropathy, this itself baseline is normal in some laboratory. So this value would be still considered normal in most of the EMG labs. So this is one of the limitation. In the older individuals, they have very less amplitudes, like less than 5 also some people may have. Sometimes for some people, sural snaps also not recordable in older age. So if, for example, in an older age patient with an old age, like more than 70 years, if the snaps are less than 3 microvolts, then we have to rethink that if it is secondary to this axonal neuropathy or this decreased sural snaps, is it consistent with the age? It is for that age, is it normal? So this is also one situation where we will get confusion if it's a normal or secondary to axonal neuropathy. And also in the obese individuals, there is an adipose tissue which is there present between the skin and the nerve. So presence of this adipose tissue decreases the travel means the impedance will be more and the sural snaps would be amplitude would be decreased. So in these situations, one thing which increases the specificity and sensitivity of axonal neuropathy is a ratio of the amplitude of sural and radial nerves. So sural radial amplitude ratio, the sural by radial amplitude ratio, if it is less than 0.4, then the sensitivity and specificity is 90% for axonal polyneuropathy. So we have to divide the amplitudes of sural nerve and radial nerve. So if axonal neuropathy, the longest nerves are involved, so sural nerve amplitudes would be much lower than that of a radial nerve amplitudes. So if this ratio is less than 0.4, then the sensitivity and specificity of that patient having axonal polyneuropathy is 90%. And also some special situations, if there is an acute presentation of axonal neuropathy, there are very rare causes of acute presentation. Normally all these axonal neuropathies have chronic presentations, like they are present since so many years. If there is acute presentation, the causes would be like Guillain-Barré syndrome, some acute causes which are causing axonal neuropathy like AMSAN, like acute motor axonal neuropathy or acute motor sensory axonal neuropathy, or porphyria, where the presentation is acute, is between the weeks, it is a weeks presentation, less than several weeks presentation, or subacute presentation, that is less than several weeks, more than several weeks to less than several months presentation. The EMG findings would be similar to that of demyelinating neuropathy. So at that time there would be some confusion. EMG findings of demyelinating neuropathy is diffuse recruitment. In acute presentations, if active denervation is not present, then also it presents with reduced recruitment with normal motor unit action potentials. In subacute presentation also, MUAP would be normal, but presence of fibrillations and fasciculations could be there, but MUAP is normal in EMG. And there are also some other situations like asymmetric involvement of axonal neuropathy. Normally this axonal neuropathy is very chronic and they present symmetrically, more first in the lower limbs, then goes to the upper limbs. So if it is asymmetric presentation or only one nerve is involved, then we have to think of these causes like mononeuritis multiplex. This is secondary to vasculitic neuropathy or entrapment neuropathy. Of the single nerve, there is some entrapment. For example, median nerve entrapment in the carpal tunnel. This can happen. So the single nerve is involved. Or superimposed neuropathy with superimposed radiculopathy also, the single nerve could be involved. When this asymmetric presentation also, we have to think of, is it axonal or not. Sometimes this axonal neuropathies, they also have non-length dependent presentations. So length dependent presentations are seen in axonal neuropathy. Length dependent, what I said, first in the lower limbs. Sometimes the proximal nerves are involved first. The proximal nerves are involved in porphyrias, and also in the diabetes, sometimes one type of neuropathy called diabetic lumbosacral plexopathy. When this is involved, the proximal nerves are involved and the patient presents with pain in the thigh and decrease in power in the thigh muscles, like they can't lift their hip. So it is called diabetic lumbosacral plexopathy. So these are some conditions where there is axonal involvement but there is a non-length dependent presentation. Now coming to the diabetes, axonal neuropathies, the prototype means the first important cause for axonal polyneuropathy is diabetes. So what are the causes? What are the types of neuropathies we see in diabetes? It's not only the single nerve is involved, like mononeuropathy. Cranial neuropathies can be involved, like third nerve, sixth nerve, or facial nerve can be involved in mononeuropathy, or intercostal nerves like thoracic radiculopathy can present in diabetic mononeuropathy, or single peripheral nerve can also be involved in diabetic mononeuropathy. Otherwise, most of the patients present with polyneuropathy in diabetes, that is a type of distal symmetrical sensory motor polyneuropathy, or sometimes they may present with pure autonomic neuropathy. Only the autonomic nerves are involved. They may have positive symptoms or negative symptoms like increased sweating or decreased sweating, tachyarrhythmias, hypotension. So sometimes pure autonomic neuropathy can also happen in diabetes. Only the small fibers which are sensory nerves, that includes pain and temperature, the nerves carrying pain and temperature, those nerves can be involved, and patient presents with burning paresthesias in the both arms. Sometimes diabetic plexopathy, it's called diabetic amyotrophy. This is also a form of diabetic neuropathy. So these are most common types of diabetic polyneuropathy. Sometimes in the axonal neuropathies, if it is a borderline case, like for example, in the axonal neuropathy, Cmaps are decreased and conduction velocities are not less than 75% of lower limit of normal. For example, if a nerve is damaged and the conduction velocity is it reaches 75%, then we have a dilemma to say if it is an axonal neuropathy or demyelinating neuropathy. So at that time we can do one test where you can see, as I already said, in the distal parts axonal neuropathy starts. So we have to see the conduction velocities in the same segment of the nerve. Here we are seeing the conduction velocity in the peroneal nerve. So here in the extensor digitorum brevis, a recording electrode is kept, and in the tibialis anterior muscle also recording electrode is kept and stimulate at the fibular neck, and we have to calculate the conduction velocity from the fibular neck to the tibialis anterior and from the fibular neck to the extensor digitorum brevis. When we do this, if the conduction velocity is same both from fibular neck to the tibialis anterior or from the fibular neck to the extensor digitorum brevis, then it is a demyelinating type of neuropathy. If the conduction velocity is normal from fibular neck to the tibialis anterior or from the fibular neck to the extensor digitorum brevis, then if the conduction velocity is normal from here to here and from fibular neck to the extensor digitorum brevis, then it is demyelination. If the conduction velocity is decreased at the EDB, then it is axonal, because axonal type of neuropathy involves the distal muscles first and then it involves the proximal muscles. That's how we can differentiate in the borderline cases where there is a dilemma between a demyelinating neuropathy versus axonal neuropathy.